So before we actually show the first video, which Alyssa and Simon have called through, I'd like to invite Dr. Alyssa Kleinman to come up and just say a couple words to create a context for what we're about to see. Alyssa?
Today we have excerpts from 3 of the videotapes made when Les, can people hear me? I can't, I'm getting a sort of feedback. When Les was invited by James Gustafson to teach residents at the University of Wisconsin in Madison. In the first tape, which we will view this morning, which is interview number 37 on the teaching website, Les is asked 2 questions by the residents. The first is the patient psychotic? And the second is that he is asked to find out something about the patient, because despite having been in their system for many years, she's become rather ahistoric and does not answer questions about herself. In the interview portion of the tape, Les demonstrates his technique of successive approximations, in which he offers statements and waits for counter-statements instead of asking questions. Note that very early on he tells her, "You cannot be paranoid enough," as if warning her off exposing too much of herself.
You can't be paranoid enough. That's one lesson I learned. You cannot be paranoid enough. But you may think of yourself as a very bad and sinful person. A lot of our citizens do. We make our living off of that part.
Actually, I tend to think that I'm rather good.
Do you?
Yeah.
Oh, that's wonderful.
Yeah.
Because I think your basic disposition is cheerful. Do you remember do you know what you were like as a little kid? Were you all round and bouncy and full of fun?
Yeah.
You were? Yeah.
Not that I remember, but I bet I was, yeah.
I bet you were too.
Yeah.
I thought when I saw your face, I bet she, whatever troubles this good lady has been through, I bet she started out as a round, bouncy, joyful kid. Huh? Well, that's good. You have that kind of constitution to build on, and you got to like a link for yourself.
I've been told quite the opposite, that I have nothing going for me.
You have nothing going for you. I hope you get those people with a frying pan when they come.
In my own mind.
In your own mind. Well,
In my own head.
Sometimes you have to take a real frying pan.
Yeah.
Some of them
I couldn't do that.
You couldn't?
No.
Well, we'd have to teach you how to do that, because there's some people you got to bat them over the head or they don't behave themselves. Now, I imagine that you have a very sunny disposition at heart. You have a sense of humor, right? Life has not beaten your sense of humor out of you. I can see that. You don't think of yourself as funny or humorous, don't you?
No.
You don't. You think of yourself as a serious person?
I don't know.
You may just think of yourself as a bad person, a flawed person,
Yeah,
or a
maybe
sick
so.
person. You think of yourself as a crazy person. A lot of people do that. We do that. That's one of the worst things we shrinks do to people.
Yeah, that's what happened was I got stuck in that position of being labeled that crazy and nutty and all that.
That's bad, yeah.
Well,
did you buy it?
Well, it makes me angry.
To
tell you the truth.
It makes you angry.
Yeah.
That's a hard thing to wash out of your hair, too. But you fought it all on, right? That's a good sign. Left school and did work with you?
Actually, I remember back then I felt pretty good. Having the salad making jobs in it that I did have way back then.
Which kind of job?
Salad making.
Salad making jobs.
Things like that and dishwashing it, but they weren't that so awfully terrible.
They were?
No, they were. I had time to sit and read a book in between, and It was like,
And you had more of your friends still in those days, too.
right, yeah. I was kind of losing, they were kind of dropping me a little by little.
Dropping you?
Yeah, back then they were
So,
kind of leaving me alone.
that's mysterious, though, right?
Well, yeah, I don't know why they did that.
Because that was how many years ago? 10, 15 years ago?
Hmm?
It was that long ago.
Yeah.
I see. So something really awful began to happen, right?
Well, what happened was they started to let me go first, and then I started feeling depressed.
Let you go first. How do you
Drop me.
drop you?
Yeah,
They dropped you as a friend?
almost totally.
Really?
Yeah, I was still in high school.
I wonder why. How strange. I wonder what was happening. Maybe had you already become depressed? Maybe.
Oh, a little bit.
You may have been
A
struggling.
little bit.
You know, what most people tell me who have that experience is that they're struggling with family problems of some kind.
Right,
Cuts them off from their friends.
Parent,
Parent trouble.
yeah.
And that's what does it. And you're afraid, and one doesn't want to tell your friends about it because it's private, and they
Yeah.
don't know what's happening to you.
Yeah, besides, I figured they wouldn't know how to advise me anyways when they're not in the
Well, that's right.
professionals
They might not.
or something.
And nobody likes to talk about their family troubles to other people, really, and as a rule,
Right,
right? If
right.
one's ashamed of it, or one doesn't understand it, or,
Yeah.
oh my goodness, oh, I'm so sorry. That interrupts the lifetimes of so many of our people, you know. Has the family troubles gotten any better? I hope so. Are they still just as bad?
I guess they've gotten better.
They have?
Yeah, I think they have. I get along pretty good with my folks now.
Are they behaving themselves better?
Sometimes they're not so cool. I mean, still.
You love them both?
Sometimes I hate them. I can't stand them.
You can say that.
Yeah.
Oh, that's a good sign. That's an awfully good sign. You know, it's an awfully good sign. The worst thing is when people who have bad family trouble can't even admit it to themselves. Can't admit how distressing and depressing and hateful it is. So when she can say like that, even with a light in her eye, she can say, I hate them sometimes. That's such a good sign. You made my day. And you tell them to their face? That's the hardest thing.
Well, I have before, but not in about 20 years.
Nothing about family.
Yeah.
Oh, families. Families. What would we do without families? But God protect us from families, right?
Well, sometimes I think that my parents kind of hate me, you know?
Yeah. Some parents too.
Yeah.
Because they may love you too and hate you too. Now they've all moved to Texas, someone told me. Is that true?
Mm-hmm. Yeah, just my parents. My brothers and sisters are all scattered around the country, most of them.
Do you have any of them here?
A sister
Do you have a sister?
and a brother.
You know, there were two reasons why she was presented. First reason was given to me when I arrived. The second reason became evident just a minute ago. First reason was that there was some difficulty finding out about her. That is, she very much resisted intrusive questioning, and even benign intrusive. Can you hear me all right? And the other reason that she was presented came out afterwards, and that was that the really difficult cases wouldn't come. So I was in the fortunate position of having a relatively easy case to talk to, instead of some of the really cantankerous people they have fighting their feet down in this clinic. And so that was a nice way to begin my little trip. And I think this is I think it's pretty evident what I was up to. Let me put it in like a good professor, let me put it in a more systematic fashion. Most interviewing is documented around what I call a pre-anesthetic surgical model. say that again. Most interviewing that we're taught, and we're all taught the same sorts of things, most interviewing is oriented around what I call a pre-anesthetic surgical model. Now, you remember what, or maybe you read about, you couldn't possibly remember, but you read about what surgery was like before the introduction of anesthesia. There were two principles in the operation of the surgeon's work before anesthesia. First was that he had to be attended by 4 or 5 extremely heavy and muscular because even if a person responded to branding widely used with somnolence, it was not predictable. And sometimes, of course, as we know too well, alcohol produces antagonism rather than anesthesia or analgesia. So that you had to have people hold the person down. And the second principle is equally important because even if you hold someone down, particularly if you're working inside the abdominal cavity, you cannot hold a person down firmly enough. So the second principle of surgery before anesthesia was speed. And some of the records established for the removal of things like gallstones, kidney stones, appendices, correction of hernias, are all measured in seconds. Quite literally. Because the principle is simple. You have to complete the operation before the patient knows what's happening. Because then they start to move. And once you start to move, you can't do anything. It's lethal enough at those rates of speed. But with a person moving, you can see that it's absolutely haphazard. Now, unfortunately, despite a few advances made in psychiatry, and not many advances have been made in psychiatry, let's face it, when I see the size of the textbooks that are sold to people, I think that the only development that has occurred in psychiatry is on the commercial side. Because we don't know very much and we don't do very well. But we have enormous amounts of books packed with information, most of which is not at all true, of course. But we are really only at the beginning of our task. And it seems to me, this is now you get on my hobby horse, it seems to me one of the first things we need to learn is how to work. I mean, how to set about the contact with the person. That would seem to be a fundamental thing, as fundamental as the learning of the physical examination is in medicine, or the neurological examination. Some of you know that the neurological examination is relatively recent. It didn't come into neurology really in a systematic way until the teens and the 20s of this century. And in my opinion, the psychological approach to the patient has not yet come into psychiatry. That's a radical position to take, but I really believe it. Just as the neurological examination, as you know it, as you learn it in medical school, in terms of a systematic development of reflex pathology, whole procedures for the detection of sensory loss, that whole thing was not systematized really until about 1935. I'm not a scholar of that, but that's what the experts suggest to me is roughly true. And in different parts of the country, in different parts of the world. But we haven't begun that yet. So, now my point. My point is that we still operate as if we were in pre-anesthetic surgery. What we do is we leap on the patient, intrude in them, and then run away. Now, if you would think of us, and maybe the analogy is misleading, if you think of us as trying to move into a post-anesthetic surgical model, you would see that various things would happen that were completely different than the way we work. First of all, you would have a long period of preparation. Most time in surgery, even today with ambulatory surgery, is preoperative. Actually, a very tiny percentage of the whole surgical time when you put pre and post-operative is surgical. So if you think of a question or getting at the vitals or something of that kind as operation in psychiatry, if we were to follow the present-day surgical model, we would have a long period of preparation and then a long period of sewing up and recovery after any such adventure, if we were going to preserve the patient and our relationship with the patient. This makes some kind of sense. Now, it's easy to illustrate with a person that will talk to nobody, right? Because there you see, you don't have any way of holding the patient down. They scoot away from you. Crazy people do that. They lose their minds. They scoot away. Most people are sufficiently sheep-like so that they hold themselves down while you do your disruptive surgery. or you use your authority as a doctor or a mental health worker to hold a person down while they have to answer your question. But I want you to know that that's really no more humane and accurate than pre-anesthetic surgery, because you don't have the guidance of the person's biological system to protect you against making intrusive mistakes. In other words, you don't know when they're bleeding. So that if we were really to do it in the way the surgeons have learned to do it, we obviously have to spend a lot of time just getting ready to make a move. Well, this little tete-a-tete you observed this morning was essentially an illustration of how one gets ready to make a move. And you saw that only toward the very end did I make a slight little move. Huh? And that to do with living in Madison, what happened to the family. And you notice that I just touched on it very, very gently. And then I closed it up slowly and I stopped it. So I was not trying to demonstrate to you that I'm a good pre-anesthetic surgeon who can rush at a person, find a lesion, grab it out, and then send the patient away bleeding. I was trying to do the opposite. I was actually doing more than I would have done if I was in my own place with my own time.
The one prescription you gave was that having an ally is a bonus. But, I mean, that was going in and offering something. But what did you
I was
think?
blackmailing the clinic.
How did that tie in with what you were saying about going in and doing something about the family? What did you think you did about the family?
Well, that followed after the evidence of her total alienation from the family. Even her sister that she's closest to is apparently very critical.
And what did you think you offered her?
I said that I essentially, and she also said how she does it her by herself. And then I tried to put the bee in her bonnet, that maybe it would be helpful to have somebody, maybe, I was being immodest like myself, who would give her a good time and maybe be available to give some advice at certain critical times. I was also talking to our two colleagues from the clinic. Maybe I was doing more than I should have, is what you're, I think, possibly implying.
No, I'm not.
Well, I wondered whether you might not be
What?
well advised to.
I was curious to ask you what you were offering in terms of the family, because maybe I had missed that. But I do remember.
I was offering that this conversation could go on. And the fact that I returned to Boston on Wednesday indicates that it won't, but there may be somebody else who would be interested in carrying it on. And I was not out of school at saying that, because our good colleagues from the clinic had essentially implied that they would like to be able to do that, and they wanted some hints as to how I might think they would start it up. So I think I was in the tradition of what they want to do and what their obvious goodwill toward this person and their flexibility in dealing with them suggested they can very well do. Let me just say a few more things about what one does preoperatively. How do you get the person into the room and on your side? That's what you want. That's what anesthesia does for the surgeon. Anesthesia and analgesia say to the terrified patient, don't worry, it's not going to hurt. You won't even know it's happening. We'll take good care of you, and when it's over, we'll sew you up properly, and we'll give you a chance to rest, and then you'll be all right. And since we all have come to believe that, even though it's sometimes not true, even though we have all come to believe that, we now go into the operating room the way the most sheep-like sheep goes into the Chicago stockyards, you know? And that's what we would like for our customers too. Because if that was the case, we would, you know, not only do better work, be happier in our work, would have much more satisfied customers the way the surgeons do, and in general hold up our head a lot higher in society than we do now. Because in society, as you know, people regard us the way they should regard us, in my opinion, as hopeless bunglers and intrusive and dangerous people. And you know, we say mental health is supposed to get a good reputation. Well, it won't get a good reputation until it does consistently good work. And, I mean, the public isn't crazy. The public isn't just scared of mental illness. I used to believe that stuff too. And I watched myself work too long and my colleagues work too long, and I know why they're scared of us. Jesus, they ought to be. Because we don't know what most of the time what we're doing, and we operate, as I say, without regard for the preparation. So what's the first principle? The first principle is to make the person feel good. Relax them. That's what the surgeons all do. They come in their white coats, they look confident and brisk. They feel like they know what they're doing. They have a lot of diplomas on the wall, and the patients that went out before you are smiling. And the orthopods are just like a good Lord Jesus. They make the kids walk, and I mean, it's everybody is delighted. And it is, it's great, it's magnificent. It gives you confidence. And so it's easy for them to make you feel good. We have a harder time. We don't know our subjects very well. As I say, we're jumping on people all the time. We're frightened ourselves. We're ignorant. It's not our fault. It's not because we're bad. We're no worse than the surgeons. We're just the same kind of creatures. So the idea is you make people feel good. And it's exactly like a surgical thing, because what you're demonstrating to the person is that if I put myself in this person's hands, I'll go on feeling good. That's what the doctor wants to convey to the patient. That if you trust me, you'll feel good. That's what patients want. Their patients don't want to know about their Oedipus complex. They don't want to know about their grandmother. They want to feel good. And so they judge you by the extent to which you seem competent in making them feel good, especially if they feel terrible. As this woman, well, she feels terrible, she feels very good. She feels better than she did. But she's been handled very well. She feels much better than she did. So you want that to be demonstrated. How do you make people feel good? Oh, come on. There, some of you could probably run in circles around me. I'm not any great social prize. But that's what you do. You try to make people feel comfortable. You want to make them feel understood. You want them to feel that you're not after humiliating them, but that you understand them and what their strengths are. You saw that little thing which I thought might have been useful, where I told her what I thought she might have been like as a kid. Well, doesn't that stand out as a possibility? I don't say it's true, but doesn't that stand as a possibility? Don't forget, in medicine, all we're concerned about is hypotheses. This is an art, not a science. So we're concerned about guesses, possibilities, what's called differential diagnosis. And so it seemed to me, maybe as a young kid, that wonderful high coloring, that blonde hair, those blue eyes, that slightly cherubic, rotund quality, all came out with a cheerful, lively youngster who may have just dived into life, innocent and joyful, and bumped her head smack up against the rotten family for preparation and naivete. Well, you can say that. Maybe it's true, maybe it's not. It wouldn't be a bad way to start. And it certainly didn't offend her much. So she began to feel maybe she wasn't such a freak. Maybe she was somebody who started out with some wonderful qualities, got lost, and might get back to them again. That even took place on the professional level, didn't it, around the whole issue of being a veterinarian, kids, cats, what it would be fun to do in life. So one carries that on, right, until the person is reasonably content. She didn't want to go. She didn't want to leave, and apparently it had been hard to have a long conversation with her previously. She didn't want to go. And that's your first principle. You want to conduct the interview in such a way that the person wants to have another one. Because for two very simple reasons. One is you can't find out much very easily, so you need more of them. And second of all, you want the person to come back so you can treat them. So that the focus of the interview should be this setting the stage, this preoperative, this analgesia, if you like, in which the pain is not of the wound or the inflammation, but of the aching soul. Anxiety, depression, sadness, yearning, blah, blah, blah. And then one, would like to get something done, so it doesn't seem just like sociability. And there I tried to move a little bit as a recommendation. The problem. She presented us with a crisis, didn't she? You see the little crisis that's reared up there? How I want to leave medicine in the state? Just after things have gotten going? Just after there's a little bit of structure? Crisis. And this young lady, if she had an offensive relationship with a member of the staff or somebody else, might pack up and be gone. And then all the work you've done might be wasted. So that's a crisis. That was one of the other reasons I brought my ally thing in. Because I wanted her to think when she leaves, will there be somebody around for me there? And then she'll remember the nice time she's had with people here, and maybe she won't go. So that was my move against change. Because this is working better. This is the best time, as far as we know, that she's had in years, maybe ever, at any time in her life. So it's a very critical, emergent thing, not to disturb it. But we can't, again, we can't jump on her and say, you gotta stay, because that'll send her right out of the state. Right? But we've got to do it gently enough so she feels not held, not forced, but tempted to stay with us.
What do you say in these kinds of situations about conducting the interview so that people don't get carried away by their hopes?
Yeah, right. Well, that's a wonderful, important question, because, and it's one that never fails to come up in particularly with psychotic people, because there's a whole movement in the treatment of psychotic people to deprive psychotic people of hope, to say they should get used to the fact that from now on they'll be dishwashers or some such thing. Now, there's a point in this. You've got to separate expectations from hopes. Now, not only is that important for psychotic patients, may I say it's useful for hopes. Where I come from, an extraordinary percentage of the people hope to win the Nobel Prize. You practice off that proportion of them that expect it. So being hopeful is good news. Being overly expectant is bad. I love to quote the novelist May Sarton, who makes the following, it seems to me, true statement. Who does the dishes without a wild vision of the future? And so when I hear one of the psychoeducation people carefully explain to me that I'm overexciting the expectations of the psychotic patients, I look at them and I ask them about what they expect to do themselves. Usually proves to be just about as crazy as what the patient was hoping for, right? But it's not crazy. It's good. We all, we'll go to our graves fighting to get that thing that we won't get, right? But it keeps us going. We want our marriages to work, and that's a terrible problem. We want our professions to blossom, and it doesn't always work that way. We hope our kids will be great. Look, sometimes it's not so good. The whole thing, but our vitality lies in the fact that no matter, even when they're shoveling us under, God damn it, we're still hoping we can pitch a little in that direction. Well, that's the way. So maybe she's not going to get to be a veterinarian. She explained to me how she can. And I didn't say, oh, no, you get to be a veterinarian. I'm not crazy, right? And as for the fact that she's too crazy to do something like that, not a chance. She's not too crazy to be a professor at Harvard. I mean, I can show you people that can't make half as much sense as she does, who are, pulling down big titles and salaries. You may even be looking at one of them.
Let me ask about this interaction between medication and biology and psychology. Because obviously you're approaching her as though this is a psychological phenomenon.
It's everything. It's all kinds of things. I am approaching her because the only way to approach a person is through their personality. You can't approach a person through their biology. Well, you can under emergency circumstances, but sooner or later you want to engage the person, if only to get the cooperation and the medication. Quite apart from the question of whether these are purely biological conditions. I don't think anything is purely biological or purely psychological. I can't imagine how nature could be constituted that way. But I don't want to get into that argument. I'm perfectly content to leave the biologists undisturbed in their conviction that these are diseases. I'm far from convinced of that myself, in the sense that if you mean by disease something like rabies or measles, I don't think we know what they are. And I don't think we're dividing them up right. But that's just my opinion. I'm trying to sell a positive thing. I don't want to get into big fights on the negative side with people. But quite apart from that, I'll accept all the biological causation they can establish. Great, more power to them. The medications have helped us. I want to see they're used right, and I want to make sure that we also do everything we can in the other department. One of the very nice things that's happened in the last 5 years is that, in my opinion, the best informed biological people now realize that there is a very important place for psychological treatment and rehabilitation. I refer you, for example, to Rolf Baldesserini's wonderful review of antipsychotic medication in the Psychiatric Times just a few weeks ago. It's a throwaway journal. He's a very scholarly man. He's our most distinguished person at heart, in my opinion, in terms of central nervous system problems in psychosis. And he makes that point. He makes 3 points. One is that the medications are not curative. They're very partial in their effects, but they're useful. Second of all, that insight treatment with most psychotic people, the way it's traditionally done, is counterproductive, which I agree with too. Thirdly, there is, however, a very large place for good what I call good management, including psychological management and understanding and development, as well as rehabilitation. Lauren Mosher represents that point of view too. So, what does that say? Well, it says we want to have our patient in very good stead. And I could go back to my surgical analogy and say, well, your appendix, that's a biological condition, but the surgeon is handling you psychologically. And he knows damn well you're not going to be a good patient. He's not going to get to operate. He won't get paid if he doesn't handle you right. And he knows damn well that if he does handle you right, you're going to be a much easier surgeon. And you're going to heal better. And you've got good evidence about that. So there's no problem with the need for what we're doing. Whatever that turns out, these things are.
Can you say something, some more about, you gave a lot of messages to this person about, I'm not going to hurt you. Besides making them comfortable, you did that in a lot of ways. Can you say more about how you planned it out? I mean, besides just the positioning of the chairs, the not staring down the person and that kind of stuff. What what kind of things?
No questions. No questions. Mind your own business. You know, it's only, that's all, that's pre-anesthetic psychiatry when you ask questions. Because when you ask questions, it's like reaching into the nervous system and sort of saying, give me. To somebody who's had profoundly difficult relationships with people, doesn't trust anyone very well. And when they do trust them, as she said, they get in trouble. So I don't want to ask. Furthermore, they're burdened. I can't count on them to help me. I have to do it. It's asking questions of most of our patients, not just psychotic patients. It's like asking somebody with acute appendicitis to do deep knee bends. Man, why the hell are you doing that? You know, I mean, they can't even split their stomach. Right? They don't have that intact ego which allows you to take a question, hear it, ask it of yourself, translate it in English, and hand it back. A big internuntial process. So what am I doing? I'll say a few things and see if I get a response. It's like a true and false question. It's easier than an essay question. So I say a few things, see if I get a little movement, see if I can develop some spontaneous thing from the person, which is what I tried to do. So she began to talk. She could have been talking still. And I don't want to talk much anyway, because the more I talk, the more trouble I'm going to unearth. What I want her is to be able to sit quietly with me and have a good time. Such a nice, comfortable time she wants to come back. And then when she's really comfortable, got a little money in the bank, then we'll spend a little. Then I'll say something to her, a little bit down the road, like, when I know she's feeling pretty comfortable and I really have to know something important. Say I hear her mother's coming to town, right? And I want to know whether she should see her mother or what I should do about it. Which, with her, it's easy, because, she did something which, made me realize that how well you've been doing, how well ahead of the game we are here. She said, sometimes I hate my parents. To me, that almost means she's definitely not a schizophrenic person. One of the bits of lore, L-O-R-E, not L-A-W, L-O-R-E, that I've accumulated over the years, is that when someone can really say something nasty about their parent, they're usually not so internally frozen, as in schizophrenia, as that. So that was good news. But if she wasn't like that, maybe she was somebody that, at the mere thought that they would think something bad of their parents, begin to hallucinate. A voice said, "You are bad," just as soon as I think of saying something negative about my dear beloved mother, right? If someone's like that and I know that the mother's coming to town, I may need to know a little bit more, so maybe I'll spend some of my goodwill. But I want to make sure I got it in the bank first.
Mm-hmm. Well, I noticed as you were talking to her and making her feel comfortable and offering positive things about her and her color and her good humor, she would say,
which quite seemed to loosen her up.
Yes,
she liked that.
She also came back with other parts. Well, yeah, it's nice, but sometimes it's not so nice. And so she gave you this little bit. But
well, what'd she tell me? She told me that sometimes she does things wrong and that she's not perfect. And she sort of And you see, there's where the doctors have to control themselves. Because we psychiatrists, knowing nothing about health, right, having no firm basis in healthy judgments about our patients, leap on every evidence of psychopathology. Now that's another thing that separates us from the internist and the surgeon. The usual examination of the physical body is almost entirely devoted to determinations of health. The pulse rate, you establish whether it's at normal limits. You look at the color, you do the respiratory rate, the reflexes. 99% of what you find is that the patient's okay, except in the area of disease, right? Psychiatry is the opposite. That's why we use adjectives. That's why we call people psychotic or neurotic, as if they were all psychotic. You don't talk that way in medicine. In medicine, you occasionally do it. You usually don't call people cancerous or tuberculous. You do call them diabetic. There are exceptions. But most of the time, you locate something. But in psychiatry, we don't speak about, schizophrenia of the maternal complex. We don't. This is the way we ought to talk, but we don't talk that way. We talk about them as being schizophrenic. So therefore, when a patient hands us what they think is a piece of pathology, we gobble it up. Well, in fact, most of the, as I said, we're all like that. I mean, there's nothing that the patient can tell us that we haven't had ourselves, even a few hallucinations maybe. But they'll give it to us and then we'll go to work on exploring their narcissistic borderline tendencies or the failure of their object relations or all these awful terms we have. We'll go to work on that, right? And they'll begin to feel creepier. In other words, what I'm saying is that rather than our being able to make pathological statements on the basis of the bits and pieces we pick up in the preliminary accounts of the patient, we can say nothing about them, except that it's too bad the person is worried. Now, I don't mean they're all right. I don't mean those problems aren't connected with their problems. But we can't say much for a long time. And so better that we say, better that we try to create an atmosphere of friendliness and investigation rather than of judgmental decision and sheer horror, which is what it's easy enough to do. But I know I'm King Canute in this one, I'm pushing back the ocean. But the average, don't forget, we have here a commercial problem. And when you're faced by a commercial problem, most of the time, you might as well throw down your arms and run home. Because in everyday practice, every profession has to find something. I don't know whether you're old and unfortunate enough to own a home yet. But when you own a home, you'll find this principle written in gold across the stars, and I mean gold. First day you own the house, you go down the cellar. You sign the papers, you thought you finally got a place you didn't have to pay rent, right? Go down the cellar, and you look around. You were afraid to look around before you bought the place. And you look around, and you see the pipes. And you forget it's summer, and in the summer all the pipes drip, right? They perspire, right? When you go down, you see the dripping. Shit. Goddamn pipes are gonna all burst. And I'm already paying twice my annual income and monthly installments. And the pipes are about to burst. And so you're right, more or less, you come up and your wife says, what's the matter? Is there a ghost down there? There's a ghost, like a ghost, I can handle the pipe. So you call up the plumber. Now the plumber is like the psychiatrist, he's a professional, right? He's been around, even though you moved into town, he's been waiting for this call. I've dealt with a lot of these people. 3 houses I bought, so I'm a pro. And the guy comes around, he's a nice guy, he feels sorry for you. He just says, fleecing you is like picking up money off the street. So he says, let me go down and look it over, probably go all right. For a minute you feel bad, and you realize, he's just luring you into his cabin. And you go down again, and he looks around. And for the most part, there's probably nothing wrong. But he says to you, it's an old system. It's an old system, that's why it's good, it works. It's an old system, they don't use that stuff anymore. We don't use lead and that stuff, They use copper. Why do they use it? It's 4 times expensive. And that's what they say. He says, we can put in copper. Wouldn't have any problem for a long time then. And he tells you the price. Now, you see the story. It's his job to find something wrong because that's how he pays his mortgage. And if you had a plumber and he says, oh, you're all right, come back and see me when you got a leak, right? You'd love the guy, and he's probably the guy you ought to find quick. right? But you're not likely to find any. When I first house I owned one day, I went out on the porch. I should never go out on that porch. And all around the base of the pillars were these little piles of sawdust piled up like some little, genie had been there. And I heard about termites. Termites. The homeowner, I don't know what it's like out here in Wisconsin, but in New England, the termite, the Russians, nuclear disaster, AIDS, nothing to it. Termites, crack the problem. So I think I got termites, And I found one of the damn things running around, proud as punch, with these little thick piles of sawdust. I picked it up, put it in the matchbox, and punching me. You won't believe this, but it's true. My next door neighbor was an industrial exterminator. Nice man, calm, sensible guy. I went running over to him, sweating like a pig. and I said, Mr. Muirhead, I have something to show you. And I opened up this stupid matchbox, and I showed him my hand. I thought it was a termite. I didn't know that termites are non-segmented. This was segmented, thank God. And he said to me, that's a carpenter ant, he said. I didn't know what that was. I said, well, he's eating my house. And he said, don't worry, Les, he said, they eat very slowly. And I went away, it made my day, my year. But my point is that the professional person who is out to exploit us to some extent is not going to give us much. And we'll all do that on occasion, I suppose, but it would be better not to have to. And in the clinic, that's the nice thing about a resident. The residents don't want any patients. The last thing you want when you're a patient. The only person you hate worst in the world when you're a resident is the admission officer. Kill the admission officer. So that you can feel good about the patient. And you can invent some pathology to entertain the supervisor.
Well, I won't have a lot of many comments, but it was very difficult. I just want to say it was very, very hard to select because there's so many wonderful moments in the tapes, and they're hard to listen to because of the sound quality a little bit, but I hope that everybody got a sense of what he was saying, and I felt like in this tape in particular he talked a great deal about being respectful of the patient and obviously not leaping on them. He always said to us, no questions, which was impossible, even less asked questions sometimes. But it was more the spirit of that you wait for somebody to emerge and you're respectful. And he also taught us something that was very liberating, I think. He tried to make us not afraid. He said, listen, you guys, most of you have friends, you know how to talk to people, you know how to make friends, you know you're all empathic people. Just don't be artificial. Just be more the way you would be in an ordinary circumstance. Don't patronize the patient by making them feel like they're a bug specimen, basically. And that was the principle more of it. In that effort, he really encouraged us to take risks and say things out of the blue, like you saw him say here about, I bet you were all round and bouncy and full of fun. I mean, that just came out of almost nowhere, not entirely, but, and then she had a chance to respond to it. So he was very encouraging of that we just, as long as we were kind and weren't trying to harm anyone, he was very encouraging of us just learning and finding our ways that way.
I could. I think that for me, one of the things that's really wonderful about watching these tapes is remembering the context in which it occurred. And I mean, I was in training around the time that these tapes were filmed, a little bit before. And the usual model is the chief resident would choose a patient, and they would try to select a patient that would make the interviewer look really good. So they would try to find one in their expertise or some way that they knew that they would, have a lot to say about it, because you wanted to be sure you gave them a chance to show off what they needed to show off. And you also were careful because you didn't want to harm the patient. And as I went on in my residency, I discovered there were a lot of interviewers that I didn't want patients to see. And so I actually followed Les's advice, and I would say, I'm sorry, the patient refused to come in, when in fact I'd never asked, but at least, and then the person who was doing, the presenter could then talk about all the things they wanted to talk about without exposing my patient to them. Because frequently the model was the patient would come in and they would get peppered with questions, and the questions would get more and more personal, and then they would start crying. And that was considered a sign of a successful interview, that you had exposed this sensitive spot in front of all these residents. And then, and usually that was somewhere toward the end, and then there would be a frantic look for Kleenex, and somebody would pass a box from the back of the room and then give it to the patient, and they would, and then it'd be over, and then the patient would leave, and usually as the resident, you went out and tried to kind of put your patient back together again, so you didn't even get to hear the commentary of the person who stayed behind, and then talked about all the things that they wanted to talk about. And Les was just so totally different from that. I mean, he said, make people feel good. That's one of the most important things, and you all know how to do that. And so when, with him, you didn't worry about which patient you chose, because you knew that, sometimes it would be a little unexpected what would happen. Sometimes he had, sort of almost enigmatic and provocative remarks, or everybody would be scratching their head afterwards. But you always felt that your patient was in safe hands, and that frequently he would do what he did in this interview. One of the things that this is a patient who didn't talk, and this is a patient that when most people tried to interview her, there was silence, and people were like, it was like pulling teeth. Did it look like that in the interview? Not at all, and that's because of his ability to sort of set the stage right away that I'm not going to probe. I want to make you feel comfortable. I'll say things that get you talking, and that's what you see. And he like the bouncy person. He says things that are perhaps an exaggeration, and then the person can correct him to kind of give a more accurate depiction of what's going on. So that was, that context was part of why he was so amazing to have him as a teacher and to have him interview your patient, because you suddenly saw them as a person in a new way, and that could completely change the treatment, because you were able to respond to the person as opposed to the symptoms or the diagnosis, both of which we were supposed to be looking at as well. I guess that's my main comment.
I'll say something. I had great difficulty hearing what was being said, combination of the muddiness of the sound and the muddiness of my hearing, I guess. But it was interesting because it forced me to look. And you see things about Les's style before the first word is said. He's sitting side by side with the patient. That was a characteristic Les strategy. He wrote about it. He felt that it related to different schools of interviewing or of getting to know people. And he demonstrated it not only in the architecture of the room, but in the style of his interview. He doesn't really have a doctor interviewing a patient. He has a conversation, which is step one in an evolving relationship, which he sees as central to the therapeutic and diagnostic process. He doesn't see an interview as tapping a keg and getting the beer out of it. He sees it as joining with the patient in brewing a new ale that will be fun and interesting. And you see that in the style of the interview. Again, I was having trouble hearing and there were no subtitles, so I had to look carefully. It's quite interesting. In the first minutes, Les is sitting with his legs crossed and the patient copies him, sits in exactly the same posture. And that happened several times during the interview, in both directions. She copies him and he also copies her. And again, that has to do with the interactive process of what's happening in front of you. He is insistent that he won't structure what goes on, that she has to join him as they co-create it. He would see the successful structuring of a detailed inquiry into her life as a failed interview. That would be filling out a form, a mental form, which is what many psychiatrists do, and what Jenny was saying, psychiatrists are trained to do in some places, you know. Similar to the medical students worry about the usual, did you have measles, mumps, chicken pox, diphtheria, whooping cough, or whatever. Later, when talking about what he was thinking about with the students, with the residents, his choice of metaphors are, to me, important and interesting. He draws heavily not on psychological theory. He doesn't talk about cognition and volition and memory, and he talks about the clinical medical model and sees this as think about and understandable about in comparison with it. So his comparison for an interview conducted by him with a patient is a surgeon who's about to do a procedure with a patient, not a psychologist who's doing psychodiagnostic testing. Les is a doctor. One of the papers read from earlier, if my memory's right, was in the New England Journal of Medicine. I think that's correct, isn't it?
Part, yeah. It was adapted from the Anatomy of a Suicide.
Anatomy of a Suicide, yeah. He very much saw himself as a physician who was practicing a type of medicine, and that what the psychiatrist was to do was very much analogous to what physicians do with patients, not what scientists do with subjects or what psychologists do with the targets of psychodiagnostic assessments. And that came through. I felt for him with the students. He was working hard there. He was frustrated by their relative silence and immobility. He didn't have an easy audience there. And it was painful to watch. When the camera panned around the room, everyone is sitting frozen, and Les is moving back and forth and stretching and pointing and pulling. And so he's working. He finally got them going a little bit with some jokes toward the end.
The insects.
Pardon?
The insects.
The insects, yeah. And he was clearly more comfortable then. And that's what he does with patients. He doesn't want to be in an asymmetric relationship as the expert or the clinician or the psychiatrist or the doctor. He wants to be in a dialogue with somebody whose attempts, that other person, the client, the patient, whatever, their attempts to make it asymmetric are interpreted by him as a resistance to his invitation to a more symmetrical interaction. And that came through in the interview. I wondered whether the noise and the sound was purposely put in, so we had to look at what was going on. Couldn't hear it, but probably that's, Les would say, too paranoid. I never felt the patient was uncomfortable, and that's a very high priority. Les would quote Sullivan at times. Sullivan said that the doctor always has to be comfortable. And if somebody in the room is uncomfortable, it ought to be the patient. I think Les would differ with Sullivan. I think Les would say nobody should be uncomfortable in the room. And if someone's uncomfortable, they're not really doing a good job of making sure that both people aren't more comfortable. I have no idea what this patient's diagnosis was, whether the patient was psychotic or not psychotic. I wondered if with her rapidly trembling, anxious movements of her hands and thighs and such, she might have had akathisia, which
She did. We had to cut out, I'm sorry to interrupt, but we had to cut out a lot of the tape. He goes through a whole thing about how she's clearly showing all these side effects and talks about the medication.
Right. Now, I'm demonstrating a bit of interesting phenomenology here. psychiatrists are most pleased with themselves when they make a medical diagnosis. Every psychiatrist's favorite personal story is the patient who came with anxiety and they figured out they had a brain tumor and got them to a neurosurgeon. Now that says something about our profession, our self-esteem, our view of ourselves. But one thing is because it's comfortable to have certainty that you're right. Until now, everything I've said has been my conjecture, my assumption, and my attempt to perform before this audience. But all of a sudden, I made a good diagnosis, and it was confirmed. And I knew what I was doing, so I will quit.
So let me, can you hear me? Let me talk about the application of this to my field, which is the field of child psychiatry. I don't know if this is going to go into that weird thing if I move it. As I said, I'm very often asked to go to hospital settings and see kids, usually state hospitals where they've been for a long time. So there's no excuse. We have a lot of those in New York still, thank God. There's no excuse for not knowing the patient. Does that work? Is that better? What about this? This? Is that better?
Yes.
Okay. Get rid of whatever that is, right? Take it off entirely. So, you know, in the waxing years of the biological approach to our field, there's a lot of emphasis on symptoms and diagnosis. And the worst kind of interview you ever see is someone who just walks in and sits down and starts asking someone about their symptoms right out of the gate. That really doesn't work with kids and adolescents. I mean, the wonderful thing about kids and adolescents is they don't hide the fact that they can really see who you are. And they will obviously not talk to you if they feel you are not someone they should talk to. They can tell by how you look at them whether or not you see them. It's much more transparent with young people, even those gnarly adolescents. But so, you know, there's a lot of confusion in my field about whether or not people are bipolar. And, you know, I always tell everyone you can't have more bipolar children and adolescents than adults. It's impossible. And there's a lot of difficulty dealing with the fact that a lot of mental health pathology comes from adverse experience. And so if you're going to be a good mental health professional, you have to know that, number one, and you have to be able to approach patients with that in a normative way. So I go into these case conferences, and I always do remind myself of Les, because I usually put the kids in a way that we're looking at each other sort of, but not the audience. And I start talking to them about, and I've always been told they won't talk about their experience. They won't talk about what happened to them. And you warm them up a little bit. You make them comfortable. You talk about their lives and their families, which sometimes is very painful, and you have to move away from that. And then I start talking to them, and they tell me what happened to them. And I go into more and more detail. And they are transformed from a person who's on lithium and Seroquel and sort of, you know, drugged, to someone who had a bunch of really impossible experiences and who really is open and able to talk about that. And their treatment team sees them literally for the first time. And I'm like, you can get rid of the lithium, you can get rid of the Seroquel. And the kids then go on, this happened about 10 times, the kids then go on to get better because they've been seen. And I think that's what Les gave me. And everything I read when I was young and before medical school and in medical school and in psychiatry allowed me not to listen to everything I was being told, but to really work to find that person. And when you genuinely find people, they genuinely give you themselves. It is a great gift that I had that guidance as I was stumbling through New York Psychoanalytic versus Columbia Psychopharm. So this is a wonderful interview, and I think his ability to make metaphors out of things that are non-psychological or psychiatric was so powerful, and going on and on about the pipes and the termites and the ants. I hope they got it. I wasn't sure they did, as Susan said.
So many times.
Yeah.
I hope you all got that.
Yeah.
He was so about not shaming people.
Right.
And nowadays, what he would make of the epic medical record. I don't know what you use in New York, but the electronic record, with all its millions of questions to fill out that you're supposed to know the first day you meet the person, when you probably should not even, know anything about them, certainly not about their trauma. It's unbelievable, but he was so into not making the patient feel us and them. That sitting side by side was more than a physical thing with Les.
It's really hard, particularly when you're young and new, because I remember when I finished your residency program, I felt competent as an adult psychiatrist because it was a very good training program. I wasn't, in retrospect, because it takes a long time. When I finished 2 years of child at Columbia, where they didn't make us work very hard, I didn't feel competent at all. Because I knew, children are like 6 different species, depending on how old they are, and then they're their parents, and it took a long, long time. So you're fed all this stuff, and you can grab onto things that really aren't right, and that really obstruct your ability to actually figure out who is in the room with you, or if they're even in the room with you, and if they're not, how do you find them? So that's why Les's work is so wonderful, because it's so accessible. And it gives you a framework that protects you from rigid dogma. The books are as wonderful as I reread several of his books before this, and Making Contact is an extraordinary book about what you actually do in psychotherapy. I mean, how many of you have ever been told what you actually do in psychotherapy, right?
So, a lot of great comments. They really get at so many elements of what was in that interview. I would add to it that I really like the idea when he says, I've got to make some money. I need to get some money in the bank before I'm going to do anything tricky. So he was always teaching, how do you deepen your alliance and find the emerging self, something that's authentically that person. So when I listened to that, I love the part where she fought back against the people being mean to her and dropping her. That kind of angry defense of her emerging self showed a lot of vitality and life. And you'd want to note that and be able to find that with her again when you need it. And so why do you do that? You do that because you want to know how the self is organized on the shame pride axis. So you watch the person's body, and as you talk to them, you don't even have to know the words. We could just watch it. You'd see when the person slides down and wants to withdraw. That's the universal body effect of shame. Head drops, you want to withdraw and melt away. Then when you find something the person's competent at, as you're kind of just conversing, the shoulders go up and back. Pride. What are they good at? And so when you see those two body movements, you now know where this person's self is organized. So that's your ally. Now you begin to know something about the person so you can explore safely, where do they fragment? Where does the self fragment? Does it fragment? It fragments in 4 ways on the acute units where I do a lot of my work. You become psychotic or delusional when the world is too hard for yourself to manage, or you fall into severe substance use, or you become despairingly suicidal, or you become homicidal. And those are sort of the 4 reasons you kind of notice when the self fragments. So in these interviews, you're trying to first find the person, their values, their interests, what makes them proud, what they're ashamed of. And you listen to the words, but the words are often a story, often a false story. But you watch the body, and you watch, where does shame enter? And you're sensitive to that because you're not trying to shame, but you want to know where that is. And you want to throw out some statements where you see them sit up straighter. And now you can work with the person. And I would think of that as the money in the bank that he's trying to develop so he can figure out what to do later. And just a detail of, if you like kind of what, for most people, this idea of not asking questions is new. So if a couple places, he makes statements, and you could see him throw out a little statement. And the importance when you throw out the statement is not to get it right. He calls them projective statements. You throw out something, like on the elevator when I'm playing this, trying it out, just playing around with it. I'll say, sunny out there, it's been so warm. Are you kidding? It rained yesterday. Weren't you here? No, I wasn't here. You live here? You know, so I mean, you kind of play, you find it, and you just see in a minute, you make a statement, God, it's hot. I love it when it's hot. I used to live in South Carolina. This is nothing compared to that. You know, and so you just throw out a projective statement, and it's not that you get it right, but the person is free to be with you, and you take them in. And that, so you can find that two really nice things in your reference list is Making Contact, that book, projective statements, or a simpler thing, the Psychiatric Clinics of North America. He talked about a couple of those operations, soundings, making a statement, and he takes it from Mark Twain and going down the Mississippi River and dropping a weight and seeing what happens. Is it 6 feet deep here? Is it 12 feet deep? And you're trying to just figure out what's here. And so that's kind of, it's embedded in that, but you can also hear some of it in some of the lectures that are on the website. The audio is perfect, like that little one that I played you a small excerpt, so you can kind of explore that way. So those are just some comments.
So we've been focusing very much this morning on the Making Contact part. It's really worth reading the other books, and even that book, which also takes you into the depth of the treatment, because now he's talking about putting money in the bank and throwing out statements. Les was very activist and very, I like to think of him as he was subversive and kind of a guerrilla fighter. So I cannot use the language the way he did. He took from Sullivan his brilliant description of what Sullivan was doing, which none of the rest of us could have understood without Les's translation. And then he developed his own language that was so, it's just, you really have to read the books to get the dialogues. And he shows you where the subversion happened. And that was kind of revolutionary. He was trained as an analyst. He wasn't supposed to have a goal for the patients. And he had a clear-cut goal that they be happier and have more meaningful lives. And he used language. I know maybe one of you can describe better how he did that. He would just, once he had the money in the bank, he would just start interjecting something just a little off, and then the patient would have to react to that. And it was often something, like he would often use Sullivan's Lord knows you always wanted to dance or something, and he would, it had to him such deep metaphoric meaning, and actually it worked. There was a way in which, okay, so maybe the authority figures are giving you permission and saying that something joyful is actually okay, but he would then proceed to introduce some of that in the treatment, and you could hear him doing it. So these are all introductory. The only disadvantage of all of these wonderful tapes is they're all introductory meetings, and he's telling us, I'm not doing much of any of that. He did a little of it here. I don't know if you could hear, he said you could take a frying pan to the family or something, but he wasn't going to do a lot of it. First, this was about the safe place and the making the relationship
Here, I wanted to do two quick comments.
Language.
One was, do you see how they were having fun? So when you work the way he's working, you and the patient have a lot of fun, even when you're exploring the darkest places. And there's a way you can move back and forth. And you know, that existential problem of people isolating a person and being mean to a person and everybody dropping away and her becoming more and more alone. That is a basic human existential question, and he's opened up a way to talk about something painful with her. He throws out a projective. It's mysterious. Right? It was a mystery, like why was this happening? He throws it out to sea. But you're learning something, they're having fun together, you're in with your partner in something that's deeply real, and there's nothing crazy about that. That's what people do to each other. They're mean. All right, and the second piece that Sullivan said, you know, an explorer of psychosis, we're all, even the most schizophrenic patient, is more human than anything else. So this thing, so often, I don't know if Les taught me this or I just thought of it as something from Sullivan through him to me, but I'll often say to patients after, quite sick by many, you can have 5 or 6 diagnostic manual, diagnoses if you look at it that way. But I'll say to them after we've had an interview, I don't know if you want to hear this, but you're far more healthy than sick. I just want you to know that. And I say it kind of tentatively because some people don't want to know they're well. And they'll say, well, what? And they'll say, well, you just talked to me, you were thinking about things, and you put it into language, and you were telling me about feelings, about the most painful things that most people hide from, and you did it, and you're right here, and I had a lovely time talking with you. I would have to say, you're far healthier than sick. There may be something in there we'll work on. And so the patient who might come out with 5 diagnoses and feel horrible feels they're kind of proud when they're walking out of the office, which is his point. The patient comes to you because they want to feel good, and I'm not hiding anything. All these things are working well, and certain things aren't. And I think you could see her come to life that way, the way that was happening.
Wanted to follow up on the no questions. I think that when Les would say, don't ask questions, one time I decided that I was really, really not going to ask any questions, and it lasted about a day. But
he asked a lot of questions in that interview.
Yeah,
but after he'd gotten somewhere.
Excuse me?
He asked a lot of questions in that interview, that they were clarifying questions often, right?
Yeah. And but it is really interesting to try it because you can ask a lot of questions by making statements and getting reactions to them. But the particular question that he often focused on was why. And he said, don't ask people why something's happening or why you're doing something. And he said part of it is, when people say why in our society, when a parent says, why did you do that to a child? They're saying you shouldn't have done that, or that was the wrong thing to do. And so you always have to think about how that particular word and question format in the society as a whole, what does it signify? And you can't get away from that when you do the interview. So if you have to ask a why question, you need to work out a detoxifying statement or question to go with it so that you're making it clear that you're not making a criticism, but you genuinely want to understand. And I think that was one thing.
There's a passage which I didn't quote in, I think it was Safe Place, where he says what's now kind of, trauma 101 language, which is all behavior has meaning. And people do the things that they do because they're doing the best they can with what they've experienced. And I think he had a very fundamental understanding that people were in the situations they were in because of what happened to them, as opposed to a more arcane, either biological explanation, and I don't mean to downplay biology because it's there and it's important, or a kind of aggressive drive kind of set of explanations. And I think obviously when you approach people, like I do a lot of work in very difficult systems like juvenile justice, and we approach kids like there's a reason, this is how you react to things. We don't say it that way. But when you approach people like that, they're much more likely to feel like you're on their side. And that was one of my problems with some of your colleagues at New York Psychoanalytic, was I always felt like when I went in the room, they made me as anxious as possible. And I was like, why would anyone want to talk to you, So, and again, I think that was that was very clear, that make the person comfortable is the first step, and help them understand that you understand there's something behind what's going on for them. And he was very poetic. His last book is almost a poem. So he could use very complicated language in a very sophisticated way, like your mother was no unmitigated blessing. Think about that. That's like 7 different things at once. And then the patient could pick whichever worked. And with kids, I tell my trainees, they often cannot acknowledge what's actually happening to them. Because if they did, and they're incapable of making their parents be bad. They just can't. It's impossible. So you're often making, I call them hypotheses. You know, I've seen a lot, this happen to a lot of kids, things like that. And the wonderful thing about children is they'll just shut you off if you're wrong. If they're comfortable, they will go with you, and if they can't bear it, they'll put up a wall, and you can feel it. And your ability to walk away from that wall, back away from that wall, teaches them that you're safe, you know, because you're going to respect their defenses. They need their defenses. And all of this comes out of my brainwashing from Les.
I'm going to pick up the notion of his avoiding asking people for their motives, usually unproductive. And I think probably in part his psychoanalytic background and training, he searches for meanings. And meanings are much more comfortable than motives or reasons or causes, because for one thing, it's easy to imagine multiple meanings. Easy to imagine that it'll have one meaning to one person and another meaning to someone else, or that will mean one meaning at one time in one's life, and the same thing looked at from another perspective at another time has a new meaning. So the meaning, again, it attaches to his interest in poetry and in language. And the exploration of the choice of metaphor or symbol is a route to finding concealed meanings. Again, that's a psychoanalytic principle, but a commonplace one. So in the interview, for example, it seemed to me that the word drop was heavily overvalued by the patient. She wasn't just rejected or excluded or ignored. She kept saying over and over again that she'd been dropped. Well, I know what that means. She meant it denotatively, but dropping means falling down and hitting something. It hurts. It means being abandoned. It means not being able to protect yourself or care for yourself. And exploring the use of words or images like that is a route to expanding the meaning that the experience has to someone. It's one of the reasons why often the most interesting things in an interview aren't the patient's answers to our questions, even if we ask questions, but rather the language the patient chooses in formulating their answer. So, how did you get along with your friends in school? Well, they dropped me. Strategy A, why did they drop you? That's the formal psychiatric interview. Strategy B, dropped. That sounds kind of uncomfortable. It's a different strategy of inquiry, which is going to lead to a different direction. It's going to make you not the interrogator who's trying to find out something about what happened, but rather the explorer who's joining the patient in searching for what the subjective experience was like that may be unconscious at this point, but is encoded in the language used to describe it.
Thank you all. I've known of Les Haven since I was a trainee in psychology at Cambridge Hospital since 1994. It's the first time I've actually seen him do a clinical interview. But he reminds me of Fred Rogers. And in some way, I guess my question for the panelists, who are all MDs, but also even in my training in the social sciences as a psychologist, and in these times, as Bob Childs, when he opened, he said, especially in these times, it just seems like, I'm curious why kindness is always a marginalized tradition. Why, how? How is it kind of understanding the, okay. Perhaps without simplifying, but I'm curious, so that's just one piece, is like, why is kindness always seem to become a marginalized tradition, and even, you know, why does it not become central in our formation of caregivers? And then secondly, it just seemed like, I'm curious, those of you who knew him, it seems like on the one hand, he was trying to conserve something about traditions of medicine, you know, with the comparison of the reassuring anesthesiologist. But at the same time, he seems like he problematized certain traditions in medicine, and I'd be curious about what you could tell us about that.
I would say something that in a safe place, he talks about the last chapter of that book is called The Future of Healing. And in that, he always was wedded, he was wedded to lots of traditions. So if you listen to the metaphors he uses, he was using that surgical metaphor and the anesthesia and all that. He was playing with that. In The Future of Healing, in the last chapter of that book, he talks about therapists or psychiatrists or whoever people doing psychotherapy need to become more like general practitioners, with the idea that you'd form a good relationship with someone. They'd come to you at a moment in their life where they needed something. You wouldn't see them for a long time, but they'd come back again maybe 5, 10, 15 years later, and there'd be something else that would be up. And he thought that is actually one of his visions for a future of healing. But it's the idea of forming connection, getting out of the way, and being there again when somebody needs you. So that might be an attempt at that metaphor. I'll just stop there.
But kindness is I wasn't joking when I said men. Kindness is a maternal characteristic and a female characteristic. I mean, Les had those qualities, and many of the wonderful men who go into this field also do. Some don't, as it is typical, but it's a devalued part of life in general. And that was what I was poking at Bob, because he used to torture me when I was a resident. But that was one of the challenges I felt with some of the psychoanalytic characters who really were making people uncomfortable, and I thought that was mean, but it's hard. And look at the world right now. It's hard to get to a place where we're able to acknowledge our weakness and our vulnerability and our need for each other. And he was a wonderful, I call him the WASP Renaissance man, because he could be this intellectual, literary character, but he also really fundamentally understood what you needed to do to make people safe. And that's what the work was.
I want to share one other comment, a quick story on that, because the kindness, and then there was something he did that most people might say he was so mean, he was so awful. And I'll just share that example, because he was incredibly kind, but he wasn't afraid to do stuff that other people might think was completely wrong. And here's an example. Alyssa and I had a classmate who was on call one night, and that night she saw a man with psychosis, and he left the emergency room, thought he'd be okay, and he jumped off a building and killed himself. And the next day, everyone was giving a lot of consolation and support to our classmate, and in this setting on the inpatient unit. And if you've ever had a patient die by suicide, you feel deeply many, many things, every range of acute emotion you will feel. But among them are, one, it wasn't my fault, and another part, it was my fault, all right? And you'll feel both those things quite intensely and want to do a lot psychologically to make that happen, but mostly you want to get away from it. Wasn't my fault. You want to get to that, but you have this other feeling that you're alone with. So everyone was giving consolation around the table and saying the person did everything she could. But Les said, I know you were up on the roof of that building with him and pushed him off. And everybody gasped and said, a few people said, you asshole, what kind of thing. They stormed out of the room with the resident. And I sat there with Les. And, I might have said something like that.
I have
was
no memory
awful.
of this. It must have been traumatic.
But that was, I said something like you were, that was
It
awful.
wasn't me, but
What he said to me was, she believes that. And she's alone with that. At least she's not alone now, okay? And I've modified that because I've gone through this myself, and I've gone through this with residents, And there's a gentler version of it. But if you saw that, you might say, he's not kind. But he was actually saying, she's there. Like, duh. She's so alone, and everybody's telling her it's not her fault. Where is she going to be with this aloneness? Like, I did something wrong, and this man's dead. And that's real, too. You see? So then there's a kind of way to get in the exploration of kindness and what is kindness that's complex.
This is a wonderful conference.
About, being the sort of medical model. I mean, I think Les saw himself very much as a doctor. In fact, he used to say, we're the only real doctors. But he
child psychiatrists are the only real psychiatrists.
Yeah, but he really just valued all branches of people who took care of people, and I think that's one of the reasons why he loved being at Cambridge Hospital, was because he worked with people in all different disciplines. And I think he saw himself as a doctor, but he had a really low intolerance for he got very irritated with the hierarchy and the bureaucracy, and sometimes he would be completely outrageous just in order to rock the boat a little bit, because he thought that some people were just, getting too conservative or, too orthodox about things.
He also looked at medicine, as the physical parts of medicine, as much more advanced than psychiatry. So, and they've had a longer time to do their work. So I think that surgical metaphor was, we were doing certain things a certain way, and we've moved forward. And he talked a lot about, he used that framework and scaffolding and that body of knowledge in a comparative way to where we were.
This is a wonderful conference. Thank you. Without being too narcissistic, I wanted to share something personal. I came to Boston in the early 70s, unfortunately at the time, to work at McLean. And I had come from Austin Riggs in the Berkshires, where the medical director was Otto Will, who was trained by Frieda von Reifman and Sullivan in the Washington, D.C. area. So Riggs was refreshing. It was highly interpersonal and relational, focusing on developing a relationship, countertransference, and being with the patient and all the things we're talking about. Unfortunately, McLean, at the time, they were opening a children's center, which is where I went. It was like going into the Catholic Church. The orthodoxy and rigidity was unbelievable. And I was lost, like I was in another world, having come from Riggs. And I called the director, Otto Will, who was one of my supervisors, and I said, you got to do something to help me. And he says, there's this guy in Boston. He just wrote this incredible book about Harry Stack Sullivan. I don't know the man, but it's a great book, and it's called Participant Observation. I was supervised by Les for almost 25 years, sometimes weekly and sometimes every other week. Excuse me, and he saved my life because I had been completely lost. So.
I want to share, it's a beautiful story, and thanks for sharing that. And I want to share an association that comes to mind. I also trained at Austin Riggs. It was after Otto Will had been the director and left. So Otto Will was analyzed by Harry Stack Sullivan. So he was trained in the tradition and kind of had introjected Harry Stack Sullivan. When he would come back, Otto Will would come back to Riggs after he had left. But when in one conference that I was at with him, they were giving this long, and they had these beautiful, 5-page summaries about the life of a patient for some conference, and Otto Will just stopped them. And he says, do you guys, I know you have a great 5-page, this story you're telling, but do you believe any of that? He said to everybody, and they said, yeah, we do, And he said, he quoted his boss, Sullivan, said, this is an act of human fiction. You don't know anything about this person's childhood. You will find out if you form in a relationship and you will feel it in your body and in your heart and in your mind as it comes to life. And then you're going to figure out what has to be worked on. These stories aren't true, you know. And so Otto Will had done that, and it's quite the tradition of Les, trying to discover through relationship what's real for this person that I might be able to assist with. And it's quite beautiful.
That was the credulity and skepticism.
I was just going to say the empathic and the, you know.
Everything is fiction until proven otherwise. So he would balance those two things. And the credulity was the existential part and necessary to get close to the person. But then when you're close, you know, you have, that's why working with children is so much easier, because you don't have to make it up. You see it right in front of you.
In watching the interview and watching Dr. Havens interview the patient, I was struck by how comfortable he was, and so I was thinking about our comfort and how important it is that most of us don't get into therapy unless we're incredibly uncomfortable. And so then the question of, okay, so how do you make somebody who's tremendously uncomfortable begin to be comfortable? You were talking about, you know, how do you teach someone to be, how do you write about being a therapist? And it sounds like I should read the book about contact. In thinking about that, in my own therapy, I remember going to my supervisor, and so I guess what I'm thinking is the way that we learn it, and I'm looking forward to reading the book, is that we watch it. You know, we watch others do therapy, usually our own therapists, or if we have a gifted teacher, right? And thinking about my own therapist, I went to my supervisor at one point, and I asked him, I said, how does this guy make these interpretations without ever saying an interpretation? You know, and then when he would ask a question, it would often be prefaced by, this is probably in deep left field, but. And you reminded me of how infrequently he would actually ask a question, although when he asked a question, he always had my attention, you know? So it's just fascinating, and I'm very glad to be here. It's lovely to hear you folks. My wife, who reads everything, read Dr. Havens years ago and told me I should come. And it really resonates. My therapist was Dan Bowie, and I don't know if they knew each other, but I have a feeling that there would be some simpatico there.
Yeah.
You know, I don't know why, but thank you so much. One of the associations to what you're saying is Les talked about counter-assumptive language, which was, he was so in tune to the balance of power between therapist and patient, and not making, again, you can't equalize it. It's this very special and particular relationship. But he could be so outrageous, so he even would advise us that we should stumble when we, entered the room. And that was fine for Les, because if he stumbled, if this, kind of godlike, powerful-seeming man who just made you feel like things were going to be okay, stumbled when he came into the room. If you, at that time, looked about 15 and, said you were this therapist, it wouldn't quite come off. But it was again, Les would do things in a dramatic way, but they made you really absorb the principle of what he meant. And then over time, you would figure out a way to do that. And it's interesting that Les looked comfortable. My experience of Les was, and I think he would say this, is that in some ways, interpersonally, he was a profoundly uncomfortable person. He wasn't just...
He found his niche, though, in psychiatry.
Yeah. It wasn't just humility, he walked the walk. He meant it. And one other thing, again, a loose association, but one thing that I remember, I think he said about teaching us about paranoia, because paranoia although at one end of a spectrum, was so much kind of a dramatic illustration of all the complexity of communication between any two people. I remember him, I think he said, well, if you ever get married someday, you'll understand paranoia. And so, when it was a way of, he didn't, I mean, narcissism, he didn't throw around these labels. He tried to humanize things so that, and his counterprojective speech is very much about figuring out when we say something, trying to notice what's going on in the patient, and from the comment they make in return, trying to figure out where they are, and then trying to say something that, trying to make the communication in a way less paranoid. That was what it was about. It was about getting out of the projective field. So.
Thank you so much. I'm actually a third year at William James, and Dr. Childs is my chair, or second chair. So does that help? Is that better? So my question is actually very relatable to the gentleman who went ahead of me. I'm just curious, I kind of got hung up on the word uncomfortable. I have never worked with psychosis, and obviously I'm learning a lot, but I've worked with a lot of terminal patients and chronic illness. And I look at healing as you can't have healing without suffering, and sort of Dr. Childs has been crucial in helping me understand sort of sitting with the person and being with the person. And I was just struck by, at the beginning when you said, we have people's lives at stake. I'm sort of in a place now, I'm working with pain care, where I don't want to cause harm, but so I want to make a person, I want to be comfortable with a person. But I'm also leery of making it too comfortable. And so I guess that word, I kind of got confused by that, because what would Dr. Havens say about the line of, suffering in a room and allowing them to feel better? I mean, my ultimate goal is always I want a person to feel good as well. But it's really difficult when somebody, is dying, and I just wasn't sure what his opinion on that would be about sort of, they're probably going to be uncomfortable, and sometimes, like he said, you're coming to therapy because you're already uncomfortable. And I just want to understand that concept a little bit better, because I was kind of taught that being uncomfortable is okay, and you have to learn how to sit with it. But I don't know.
May I ask, you mean speaking about how uncomfortable you feel because you're in the presence of somebody who's dying?
More so that, yes, that part, but also more so like the patient is uncomfortable with what they are feeling. And I don't want to take that away from them. So sort of you want someone to feel better and be able to open up and talk about the pain they're in. So I guess I was interpreting this, you want them to feel comfortable as you don't want them to be hurting anymore. But I'm not sure that's even possible.
That was in the beginning, the comfort part. He was pretty clear about that in that interview, that he was trying to make that young
just
woman.
Initially.
Yeah, well, yeah. And if you read something like Making Contact, which goes through a whole course of therapy, he was very. It was like a war. You were taking part in a war with the patient, and you had to be very careful because you could do the wrong thing and push people in. But that part wasn't easy. But the comfort was making the person feel safe, and the humility was making the person feel safe and also powerful themselves. But because the work isn't comfortable. And getting, and that's one of I tell young people, if you can't deal with the fact that people do horrible things to other people, don't go into the field, right? Because you're going to have to sit with that and feel and be empathic with that and help people with that and feel hurt yourself by what is done, particularly when you work with kids. But you have to help with that, and you can't do it if you can't actually sit with that discomfort. Same with death. the people who have wonderful deaths are people who around them allow them to go through that process and know that they're on the other side, it's better. And that state of grace you can have in the presence of a dying person helps a dying person die.
That I so admire the kind of work that you're doing, and I think it's so difficult to stay in the company of someone who's going through that. I just want to share that Les and I had a mentor in common who was an amazing person, Doris Menzer-Benarin, and she was very crucial to me and central to my life, but as she aged and was losing some of her power and her outrageousness, I went to Les, and he shared with me what happened to him and what his experience was when his mentor was going through changes and fading and so on. It was such a profound lesson. I felt that he gave me permission to keep in her company still, even though she was so different and so altered. So I think keeping company with someone who's going through such just a profound degree of suffering and knows they're dying is just, I don't know. If there is a God, it's God's work. I don't know.
So we have about 15 minutes left, and I think there's 3 more questions. So, Ben?
Alex, you told the story of the resident who lost a patient to suicide, and it sounded like Les had very strong feelings about that. I'm wondering if Leston had ever lost a patient to suicide, and if you had been able to witness his reaction to that.
You're asking, if he had pain related to suicide?
If he lost
He lost a patient.
Yeah, well, he came to my aid when probably the most traumatic suicide experience I had was when I was a clinical director at No, can't hear me?
The question was whether Leston had himself lost a patient to suicide.
Well, I'm answering it.
Okay.
Here's the way I'm answering it. I'm giving you the context. So I had lost a patient, a painful experience, and I was kind of distraught about what had happened. And I'd kind of managed things for a few days, what I needed to do. And I was a clinical director at McLean at the time, and I called up Les after a lot of emotional pain came my way. And when I talked to him on the phone, his answer to me was, I know what this feels like. It's happened to me enough so that I know what this feels like. And he said, can you come and see me like tomorrow or the next day? And so when I went and saw him, he offered various forms of comfort to me. I didn't explore with him about losing a patient to suicide. There was another point in our relationship where I had come back to see him after having been away for a long time. And we had a great time together, and then he just sort of disappeared without saying goodbye. He just kind of walked away, and there was no handshake, hug, acknowledgement. And I wrote him a note about it. And because I came back out to Western Mass, and maybe about a month later, he wrote back to me and said, sometimes you unearth me and scare me, and I turn away. And he related that to a turning away, and perhaps sometime he wasn't available in his own life to somebody who needed him. And so there was something, and he followed that comment with, sometimes maybe the best we can do is save a patient. And there's a doctor who I knew who was going to die, and I'm able to find him. And when I found him, he's alive today, and he's out of danger as much as that's ever possible. But sometimes we can't save even those closest to us. And that was quite a similar experience to me in my own life. So in some way, he and I never talked more directly than those sharings, but they were probably part of the deepest connection he and I had. And it was about the matter of suicide and about the matter of trying to save people in our own lives, and we can't sometimes. and how the work sometimes we're able to do what we couldn't do with people we weren't able to help, though we loved. So I'll leave it at that. Yeah.
I just want to make a little edit on the suicide question. When Les was at Mass Mental Health Center, he was the chief of service, and then he was something called the super chief. And those inpatient services were very active, severely ill patients. And there were some suicides on those units frequently, not necessarily on the unit, but perhaps if the patient had gone home or whatever. And during the time that Les was there, he started something which was called the Suicide Review. And it was a rounds in which everybody sat down to try to figure out what had happened. What I know is that he felt that was his responsibility, even though the person was not his patient. He was someone who took a tremendous amount of responsibility, sometimes too much. There also is a patient who he saw in his private practice for a long time who just simply would not come to appointments. And his belief was that he couldn't do anything else, and it also wasn't a situation in which you'd be committing this person. He had a hunch that this person just didn't want to stick around. And then the Anatomy of a Suicide paper is the earliest, real ruminations about this. But then later he did a lot of work in some of the audio lectures where he talks about, this is in the language of psychotherapy, I think, where he talks about digging deeper and saying to people who are suicidal, there's no way you can live. And he'd keep digging deeper and deeper and deeper until he'd get to the bottom of it, until they would say, he hoped they would say, well, that's not really true. It's not that bad, doc. So there's a lot of that. And the only other thing that I wanted to say about the comment about his being a physician, he always felt he was a physician first. When he was at medical school, he took a whole residency in internal medicine. And I believe he was also the chief resident. The reason he did that was that he believed in the mind and body.
2 years.
And he also believed that you didn't have any business talking about the body if you hadn't studied it. So he wanted to know, one of his mentors, I believe at the time, was a neurologist, and that made sense to him because he was trying to figure out the mind-body connection. The other thing is that he went to the Institute because he wanted to know how the Psychoanalytic Institute worked, because he didn't feel he could write about it if he didn't know. Frankly, he couldn't stand it, but he did it, and he also was in the Army. It was a similar thing. I'm going to do it. I'll do it. I do what I have to. And then also his study of Sullivan, he found Sullivan to be a mystery. And I think one of the biggest things that we saw a little bit in the videos is the moving around of chairs. And Sullivan used to talk about how important it was to take a bus ride with your patient. So he'd talk about, if you're sitting on the bus and you're sitting with someone and you're both going to the same place and you're staring forward, right? You're not staring at each other. You're looking at, mostly at the front. And then, I don't know about the second video, but in some of them, he spends about 10 minutes figuring out the chairs based on what the residents have said. So if the patient he thinks might be skittish, then he would move quite far away and sort of be sideways. And then if things got better, he might move his chair. So I think what Dr. Michaels was seeing in this grainy video was a lot of this body language, where he was quite restless, and the patient was nudgy too, but they were taking these cues. And I also think, just as a advertisement for the website, that when you look at these videos in a smaller format, and you turn the volume down a little bit, you really can hear.
Yeah.
But, maybe there was a reason so that Bob Michaels could comment on body language today. Maybe there was a reason that this happened. So I think that is all I have to say. Oh, no, drugs, that's right. There's a whole slew of stuff that we put on the website. He did psychopharmacological drug research because he said, I don't have any business talking about drugs unless I know what they are. So, thanks.
I think we're about to close, but I have a quick, short anecdote that feels relevant because it's about Otto Will, who we've talked about, and Harry Stack Sullivan. And I had an occasion to be very close to Dr. Will for a number of years. We met regularly once a month in my office, and his job was to soothe me. I had
Which isn't easy.
Which isn't easy. Which isn't easy. I had just become chairman of a big psychiatry department, which is one of the loneliest jobs in the world because everyone around you is under you in some sense, administratively, and so you need a friend. And Will was head of Austin Riggs, and Will was a member of my faculty by chance. So he immediately, when I became chairman, contacted me and offered to resign because he said, I don't do anything useful, you don't need me. And I said, I need you. You do one thing useful, you come down here once a month and talk to me. And we spent a significant amount of time together and I got to know him. And he told me an anecdote that I've always treasured and remembered because it was even more than Les's writing. It's the thing that made Sullivan alive to me. I never met Sullivan. And it was that Will was in analysis with Sullivan. And to paint the picture a little bit, Will looked like John Wayne. He was about 6'4" and he wore cowboy boots and he came from Colorado and you expected him to have a lariat and be sitting on a saddle all the time.
He had a very deep voice.
Yes, yes. He looked like John Wayne. And Sullivan was a little tubercular, thin, coughing, chronically ill man. And Will was enraged one day at Sullivan about something or other. And he was lying on the couch and ranting and raving about how much he hated him and what a bastard he was, et cetera, et cetera. The session was over and he got up and looked over and he saw this little man coughing and may not make it till tomorrow's session. And he felt terrible, he told me, for the way he'd been talking to him. And he said, Dr. Sullivan, I want you to know I know this is all transference. I understand that. And I really don't have those feelings about you. And Sullivan replied, Dr. Will, I don't think that's true. I think you hate me. And furthermore, I think I hate you too. That is a category of interaction that goes with saying, you were up on the roof with her, pushing her off. It is ignoring the defensive denial and avoidance and making contact in a way that makes sure that the subject knows he's not alone. That's Haven's brilliance.